Hi, my name is Manali Kamdar. I'm an associate professor at the University of Colorado Anschutz Cancer Center. Mantle cell lymphoma is a subtype of lymphoma that is very heterogeneous, with some patients having an indolent presentation versus the others who have a classic mantle cell lymphoma presentation, versus a few who have highly aggressive mantle cells such as blastoid or mantle cell with TP53 mutation. For the longest time, when we approach patients with regards to management for mantle cell lymphoma, we typically look at their fitness. In patients who are medically fit, we have offered these patients with intensive chemotherapy, followed by an auto transplant, followed by rituximab maintenance for a total of 3 years. This strategy has been able to take care of these patients roughly for about 7 to 10 years, after which most of these patients will still continue to relapse. On the other hand, for patients who are medically unfit, in terms of the elderly cohort, these are the patients we, of course, are not able to provide long-term durable strategies, since auto transplant is something that they don't very well, that they cannot tolerate. As a result, for the longest time, in patients who are transplant ineligible or elderly patients with mantle cell lymphoma, we typically approach these patients with a combination of chemoimmunotherapy with rituximab maintenance. In terms of chemoimmunotherapy, we typically approach these patients with bendamustine plus rituximab for a total of 6 cycles. And looking across multiple clinical trials, we can say that we are able to potentially give them a progression-free survival benefit of about 3 to 4 years, which means after 3 to 4 years, we are again looking at these patients relapsing, thus needing novel treatments. Bruton tyrosine kinase inhibitors or BTK inhibitors have made a huge impact in several subtypes of lymphomas, particularly in patients with relapsed mantle cell lymphoma. Bruton tyrosine kinase inhibitors like ibrutinib have actually helped in terms of outcomes and manageable toxicity for patients with relapsed mantle cell lymphoma, with an overall response rate of over 60% and a complete response rate of 21%, buying them about a progression-free survival of nearly 2 to 4 years. As a result, it's of course obvious to test it in the frontline setting. And with that in mind, the SHINE trial was designed now nearly 10 years ago. SHINE is a double-blind randomized control phase 3 study, which involved nearly 500 patients of ages over or at 65. The enrollment took place way back in 2013 and 2014. The trial compared ibrutinib plus bendamustine rituximab versus placebo plus bendamustine rituximab, with a continuous BTK inhibitor therapy that was administered alongside rituximab maintenance in the test arm. The primary endpoint of the study was investigator-assessed progression-free survival. Median age of the study, or in both arms, was 71 years, and the patient characteristics in both arms were fairly matched. The histology was also fairly matched, and in each arm, there were high-risk mantle cell lymphoma patients, roughly about 9 to 10%, with either blastoid, pleomorphic, or TP53 mutation. The net of this study was that the complete response rate was 66% in the BRI arm, so bendamustine rituximab ibrutinib, versus 58% at a p-value of 0.057. The addition of ibrutinib led to a highly significant improvement in progression-free survival, translating into a hazard ratio of 0.75, thus identifying a 25% reduction in the risk of progression or death if patients were randomized to bendamustine rituximab plus ibrutinib, followed by ibrutinib rituximab. The ibrutinib was actually given until progression. At a median follow-up of nearly 7 years, the progression-free survival on the BRI arm was 6.7 years versus only 4.4 years with bendamustine rituximab. Roughly, this 2 to 3 year gain in median PFS is technically not just statistically significant, but in my opinion, also clinically meaningful. And this PFS advantage was seen across all subgroups, except for patients with the highest risk scores, or the blastoid morphology patients or the TP53 mutation positive patients. At this point in time, I will say, in terms of toxicity though, patients who received BRI had a significantly higher toxicity profile versus patients who received bendamustine rituximab alone. The toxicities with ibrutinib were all well known now, but 10 years ago, our approach to managing those toxicities were probably different. Nonetheless, there was a higher incidence of atrial fibrillation, rash, infection on the ibrutinib arm. However, there was no increase in major bleeding, and the second primary malignancies at this median follow-up was equivalent. This study allowed for a crossover, meaning patients who received BR, when they progressed, they were able to cross over and get ibrutinib. As a result of which, at this point in time, despite a long follow-up, there is no improvement in overall survival. However, with such an impressive progression-free survival advantage, one would wonder if this could actually become the new standard of care for patients who have transplant ineligible or patients who are older and unfit with new diagnosis of mantle cell lymphoma. At this point in time, the incorporation into clinical practice remains debatable because clearly there are two schools of thought. The one school of thought saying that the trial met its statistically significant primary endpoint, which was progression-free survival. And if the patients are able to enjoy a 3.5, 4 years of increased progression-free survival, then it may be of value to give this to patients. On the other hand, the second school of thought focuses more on the toxicity, meaning patients who did have ibrutinib, they did have higher grade 3-4 toxicities. And clearly, I think there are two camps at this point in time. I would say I would potentially consider bendamustine rituximab ibrutinib, but I would have an extremely low threshold to stop ibrutinib if the patients demonstrate any toxicity. In terms of the SHINE study, at this point in time, we don't have the approval by the FDA to use BTK inhibitor in the upfront setting, but there are certain times when we really hesitate to use chemoimmunotherapy for the high-risk subgroups like TP53, blastoid, pleomorphic mantle cell lymphoma, complex karyotype, patients who have a Notch1 mutation, c-Myc rearrangement. I think in those patients, we all do know that historically chemoimmunotherapy is not really helpful. And I think if this regimen was to be brought into the first-line setting, I would potentially incorporate ibrutinib as a chemo-free strategy, especially for the high-risk mantle cell lymphoma patients.